DFweb as an ePro solution. So this is just sort of our experience in trying to make that work and what we did and what we learned. So the basic study design, it was actually 3 separate studies. They were identical and they were running in parallel. Each study had 3 visits. They had a baseline visit. There was a questionnaire that the participant completed at that first visit. And then there were 2 treatment visits after that, but they would only complete questionnaires at one of them based on their randomization. For the treatment visit, there was a VAS scale, and that was at 9 timed intervals. So it was very specific timing on when they were supposed to complete these questionnaires. And then between the time 1 and time 2, there was a multiple choice questionnaire that had to be completed as well. So there's a lot of very specific timing of all of this, and that's one of the reasons why we thought we would try to use DFweb instead of paper for this trial. It seemed to be a good fit for a first-time effort. The technology that we used, we started with the iPad mini, mostly because they were immediately available and they wanted to start these studies very soon. So we started working with those. We did find that there were some issues, like the fields were really small, and these were with potentially older adults. So we thought they might have some issues. So we did end up being able to access iPad Pro, which is almost the size of the paper. We did want to use the paper background as a backup. So that's why we didn't use a eCRF in this either. When we set up the iPad, the tablet, we loaded Chrome onto their audit, and that was pretty much the only thing that they could access. And then we preloaded DFweb address into the browser. So all the site had to do was open Chrome, DFweb was there, and then they could start guiding the participant into entering their data. We also created a user ID spreadsheet. I think this had been brought up in a previous DFUG meeting. So that's where I got the idea to do this. It's the list of the users that the site could have, and then we preset their temporary password so that the site could assign the usernames and then they could immediately reset their password as they needed. Since the visits between baseline and visit 2 or 3 could either be 14 days or 28 days, we were concerned that they might forget their password. Shocking, I know. So we provided these reminder cards, and the site could fill out their username, and then the subject could record their password that they created. Then one copy was kept in an envelope at the site, a sealed envelope, and then the participant could put the other one in their wallet. So the next time they came back and needed to complete their questionnaires, they would have that available. We did use the site coordinator email for password resets in DFadmin for all of the subject users. That was just in case something happened and they needed to reset a password. There really isn't a mechanism for the user to reset their own password because we cannot access their personal email. So this worked for a clinical setting very well. As I said, we did use barcoded forms as a backup. We did need them a couple of times. Partly we were concerned because the timing was so critical to the data collection that if anything did happen and they couldn't immediately resolve it, that this was a ready backup just in case. And we did need it a couple of times. But for the most part, the iPads worked very well. We're pretty happy. We didn't get a lot of feedback that the participants had issues handling the technology, or at least, no more than normal. We consider maybe the iPad mini, if we did use it outside of a clinical setting for at-home recording, it might be easier just because it's more portable and it's easier for a participant to carry around with them. But at this point, the mini is a little bit more awkward if you're using a barcoded form. So our setup, we had to do a few things with our setup, mostly because our conventions are a little bit different. We had to reset our visit numbers so that they were exactly formatted as they are in the visit map. We couldn't have any leading zeros in DFweb or it wouldn't recognize the form. So again, it's just a little format thing that we had to fix. Our validation level for data entry is level 3 instead of level 1. So we did have to reset that in our roles. And we use an edit to preset the site user, so they only enter at level 3. So we just had a few things that we had to accommodate to make sure that the subject could enter their data at level 1, but then everything else was entered at level 3 by the site. We did use DF Open Patient Binder for a few edits. We used subject as initials as a secondary identifier for the subject when they opened up their questionnaires. The problem was we only collect that on page 1, which is our eligibility form, and we didn't want them to see the eligibility form, but in order for them to pull the initials forward using an edit, they had to have access. So we gave them access to it view only, and then we hid it using DF Open Patient Binder. So the patient was not aware that they even had access to that, but they were still allowed the functionality of seeing their initials so that they could confirm that they were who they said they were or who they thought they were. And then we also used it to hide, they would see the baseline form when they came in for visit 1 and only the baseline forms. Once they completed that, and then they came in for the next visit where they needed to complete questionnaires, that's when they could see the other questionnaires, but not until after baseline. And we just figured it would be easier for the site because they would, leave the participant sort of alone while they finished the questionnaire, and then we wouldn't be worried that they would continue and complete the other questionnaires for the next visit by mistake. So when we trained the sites, we scheduled, instead of trying to incorporate it into our investigator meeting, we set up separate meetings with just the personnel who were going to be working with the participants. We sent the iPads early, and we had them make sure that they were loaded, that they were charged, and we did a very hands-on training with all of the personnel. They only expected to really have 2 participants in the office at the same time, but we sent 4 iPads just for redundancy. And we tried to make sure that during this training, everybody used an iPad. They tested all 4 of them so that to make sure that they did actually work in their setting, because they had to set the Wi-Fi up and everything too. So we had test IDs that the site personnel could use. So they actually went in as themselves to set it up as they would when a participant arrived. And then we would switch over and they would become a participant so that they would get the full experience of having to fill out the questionnaires for a baseline visit and then come in for their second visit and fill out all of those questionnaires. So we think that helped them gain an experience, not just with the technology that was new to them, but also gain some perspective on how they would have to approach things when they had participants in the office. We had a few scenarios, a normal visit that went exactly how was this supposed to. And then we had a few where things didn't go as they were expected, which we often encounter anyway. So we had some experiences that we learned from as we were testing and working out how to do this. We went over password resets, if they had to remove a question, because some things were conditional statements. So if they had to change a response, and then we went over saving records, because that was very important, because if it times out, it didn't save the information. So we want to make sure that they understood how to direct the participant how to save records. So a few things that we learned. So one thing would be really nice is if there was a way for a participant to reset their own password. We know that DFweb is not intended for ePro, so that makes sense, but that's why it's nice for when you're only using it in a clinical setting. Then we can use one of the coordinators' names for a temporary password reset if we needed to. Initially, we had an edit that removed the baseline questionnaire once it was completed so that when they came in for their next visit, they couldn't go back and change their baseline questions. But that ran into a couple of issues where they only partially completed the baseline and then they had to go back, but they couldn't. And this was found during testing. So this was another reason why having a separate meeting with the site personnel was helpful, because we were able to make that correction before they actually enrolled subjects. And we really had very few issues with missing data, meaning by, with technology issues. A couple of blank forms, but it was really only 4 out of probably several hundred forms that we received for this study. So overall, it worked out well. As I said, the one issue was that the iPad timed out, and DFweb did not save the information. It just obliterated it. So then they had to go back. And I think we missed that time point for that reason. What worked? Well, a lot actually worked. The VEST scales we found to be very challenging on paper forms. You know, they don't cross the line. They'll do 2 lines. They'll do a really fat line. They'll write a smiley face. They'll circle things. They'll circle several things. So by using the iPads, we're able to eliminate all of those things that we always see whenever we use paper. So that was really helpful. And that gave us complete data, and it came much faster too. These were very fast running studies, and they wanted the data as soon as possible, and this really allowed them to see things immediately after they were completed. Changing the email to the DFadmin coordinator, or to the site coordinator and DFadmin, was really helpful. It wasn't how we initially set it up, and then we kind of came to that idea later, but that really worked well for the clinical setting completion, which is why we probably at this point aren't looking to do it for an at-home data collection. But it was such a good experience that we're actually implementing the same process in an upcoming study, but it's also a clinical setting where they're doing all the data collection. So we think it'll work out well.